Hello and welcome to the AMCP podcast series, Listen Up, as we take a deep dive into the challenges, trends, and opportunities in managed care pharmacy. Follow the show's social hashtag at AMCP Listen Up, and to learn more about AMCP, visit amcp.org. I'm your host, Fred Goldstein. On this episode, my guest is Hilly Paige, Chief Innovation Officer of the Family Heart Foundation. Welcome, Hilly.
Well, thank you, Fred. Thanks for having me on. I really appreciate it.
It's a pleasure to get you on. We're here at the AMCP 2024 annual conference. Obviously, you've been here for the whole conference. A little bit of your sense of it.
It's been a great show so far. I think the turnout and the attendance has been really strong. I think they said close to 4,000, which is great to see. You know, we go to a lot of the medical meetings, and it's great to see post-COVID. The meetings are coming back. Last week, we were at the American College of Cardiology meeting, and it felt like pre-COVID days. You know, the exhibit hall was full. Lots of exhibitors, great sessions, and very much the same here. So it's great to see that medical meetings are back live and in person, and we're kind of past the COVID lockdown phase, and the sessions have been good, and we've had a lot of great traffic to our booth.
Well, fantastic. Tell us a little bit about your background and the Family Heart Foundation.
Sure. So we are the Family Heart Foundation. And as you mentioned, I'm the Chief Innovation Officer. I joined the organization about 18 months ago after 30 plus years in the pharmaceutical industry. So I started a long time ago in the late 1980s as a sales rep with Parke-Davis, and kind of continued my career through sales training, marketing for 5 different companies over the years, starting with Parke-Davis and going through Novartis and Daiichi Sankyo, Aspirion, Amgen. And so long time there. And then just about 18 months ago, decided to leave the industry and join the Family Heart Foundation. And it's really been a wonderful, I'd never worked on the nonprofit side. It has been really so rewarding for me because of the work that we do. And just a word or two about the Family Heart Foundation. So we were founded in 2011 originally as the FH, or Familial Hypercholesterolemia Foundation. And familial hypercholesterolemia, for your audience, is a disorder of one of the LDL receptors. It clears LDL out of your blood. And so we have 2 receptors or 2 genes that code for the LDL receptor. And if one of them is defective, you have heterozygous FH, which occurs in about 1 in 250 individuals. And if you have homozygous FH, you have a defect in both of the receptors, and that occurs about 1 in 300,000 individuals and leads to very premature cardiovascular disease. And so it's not a rare condition, FH, and the CEO and founder of the organization, Catherine Weilman, actually had a heart attack when she was 39, a young mother, had been told all her life that she had high cholesterol, that it ran in the family, had never gotten a diagnosis of FH. And she finally, after the heart attack, got the diagnosis and the designation that she had FH. Decided that she looked around and said, there's no support for folks that have FH. There's no education. And so she founded the FH Foundation at the time. And then about 3 years ago, so there are about 1 to 2 million people in the US who have FH. And about 3 years ago, we expanded the mission to include people with high lipoprotein(a). So high levels of lipoprotein(a) occur in about 1 in 5 individuals, or 20% of the population. So there are probably 60 million people in the US that have a high level of lipoprotein(a), and the diagnosis rate, though, is only about 1%. So incredibly underrecognized because it's not part of a standard lipid panel. Most people don't know about it. Most people don't get tested. But our founder, Catherine, has both FH and high lipoprotein(a), and oftentimes they run together in a lot of folks. And so that's why we decided to expand the mission of the organization. We became the Family Heart Foundation. And so that's kind of a long-winded explanation of how we started as the FH, or Familial Hypercholesterolemia Foundation, and are now the Family Heart Foundation.
And so with these 2 conditions, you said a number of individuals just don't actually know they have this condition. So how would they go about finding that out?
Sure. So for FH, you can certainly get diagnosed. The hallmark is a really high level of cholesterol, or LDL cholesterol. And so it's usually picked up in either childhood or in your teenage years. But oftentimes you don't get the diagnosis of FH. So what you're told is, you've got high cholesterol, watch your diet. And unfortunately, when your cholesterol is 300 or 350 or 400, you can watch your diet all you want, and it's not going to really impact it to any great extent. And so that's why we really feel it's so important to actually get a diagnosis of FH, because then you know the condition you have. It's genetic. And you can actually work with your family and do what we call cascade screening to actually get out to your parents or your children or your siblings. Because if you have FH, there's a 50% chance that either one of your parents has it or one of your kids has it. So important to do the screening. And right now, the diagnosis rate for FH is about 30%. For lipoprotein(a), because it's not part of a standard lipid panel. So if you go to the doctor and you get your lipids done, you get an LDL and a total cholesterol and HDL and triglycerides. Lp(a) is not part of a standard lipid panel. So it's something you actually have to ask your doctor for. And this is one of the areas where the Europeans have been a little bit ahead of us in terms of the guidelines. So the guidelines for a lot of the European organizations like European Society of Cardiology and European Atherosclerosis Society says everybody once in your lifetime should get tested for Lp(a). And the US organizations have been kind of behind on that. They've said, well, if you have a positive family history or you're high risk or you've already had an event, then maybe test yourself for Lp(a). But just recently, maybe 2 weeks ago, the National Lipid Association came out and said, everybody should get tested at least once. And the nice thing with lipoprotein(a), because it's genetically determined, it's incredibly stable through most of your life. And so if you test your Lp(a) level from the teenage years onward, if you're high, you're high. If you're low, you're low. It is very stable and not much affects it. So diet, exercise, nothing really affects it. And so it's an easy test to get if you know what the test is and you know to ask for it. And it's important. And that's one of the things we really advocate for is to everybody should get screened.
So are you advocating that to both the general population as well as physicians, or one group over the other?
Yeah, we're out at all sorts of meetings. So we're trying to raise awareness with the payer community because we find in a lot of cases the test is not covered by insurance. So somebody then has to pay out of pocket for the test. Now, that's if you go through your doctor. You can also go through a company like Let's Get Checked or LabCorp or something and order the test directly. But there it's $80 to $90. And a lot of people are just kind of unwilling to pay $80 to $90. So we really advocate for better coverage. With healthcare practitioners, what we hear oftentimes is, well, there's no available therapy to treat your high level of lipoprotein(a), so why should I test it? Why should I worry the patient? There's nothing you can really do. And the sad thing is that the patient has the right to know if they have a high level of lipoprotein(a), and there is something you can do in the here and now, because if you address all the other cardiovascular risk factors you have, like high blood pressure and high glucose and smoking and lose weight, all those things will dramatically reduce your risk, even if you have a high level of lipoprotein(a). So there's something that patients can do now. There's something that healthcare practitioners can do now. And so that's why we're really trying to get out there and with all the stakeholders, raise awareness of it's a powerful risk factor, it's under-recognized, and people need to be screened.
So they can do those wraparound healthcare things to take care of, or at least lower the risk level of that condition. And for FH, is there some treatment there?
There definitely is. So there are a lot of wonderful therapies for people who have high levels of LDL cholesterol. And so, the standard for years has been statins. And statins have been around since the 1980s, and they're all generic now, and they're wonderfully effective and in general available for most folks. Ezetimibe is typically the first add-on therapy, and that will lower LDL another 15 to 20% on top of a statin. And then beyond that, we have a lot of revolutionary therapies like the PCSK9 inhibitors. The first one was approved back in 2015. Actually, the first two were approved back in 2015, and they'll lower the LDL an additional 50% on top of whatever you're currently taking. And so it's really been such a revolution, Fred, between the 1980s, where if somebody had either heterozygous or homozygous FH, they were doomed to have an early cardiovascular event, a shortened lifespan. And it's amazing now, because of all of the technology and the drugs that are available, we can get most people controlled to a very normal level of LDL, whether you have heterozygous, the less severe form, or even now homozygous FH. There are some of the ANGPTL3 inhibitors like evinacumab from Regeneron that lowers 50%, the LDL 50%. And that has allowed people with HoFH, who typically start with cholesterol 800 to 1,000, to actually normalize their cholesterol. So it's really wonderful to see in the last 10 to 15 years an incredible advance in therapies that have made this condition manageable if you know about it, and if you're aware, and if you actually seek treatment.
So it really is about making people aware of the situation, providers aware. And obviously you're at this AMCP conference. What's the purpose here?
So the purpose here really is twofold. So we want to raise awareness around lipoprotein(a) and that part of our mission. The broader part of our mission really, I think, is focused around better control overall of LDL cholesterol. So cardiovascular disease, as you know, is the number one killer of Americans, leading cause of death. And unfortunately, for a long time, we were making great progress against cardiovascular disease. So in the 70s, the 80s, the 90s, we had all these new treatments, these new available therapies, these new procedures, and there was steady year-over-year decrease. And then in around 2010, we plateaued in terms of the rate of cardiovascular deaths and the total number of cardiovascular deaths. And now every year since 2010, that rate of cardiovascular death is actually increasing in this country. So we're losing ground in terms of something that is, in general, 80% modifiable and preventable cardiovascular disease. And so one of the major modifiable risk factors is LDL cholesterol. And while our population is only 1 in 250 and only 1 to 2 million, we really have the sense that a rising tide will lift all boats. So if LDL control in general gets better, it's going to get better for people with FH. And so we're very focused at these sorts of meetings on trying to improve LDL control for high-risk Americans, which includes people with cardiovascular disease, people with FH. And that was the session that we had on Tuesday afternoon, was very much focused on how are we doing in terms of LDL control? How can we do better? And we had a little taste in there of lipoprotein(a), and just to sensitize people to that as a risk factor.
And is there any research going on around lipoprotein(a) and what maybe can be done for that?
There is. Let me say just one more word on LDL, because one of the great assets that the Family Heart Foundation has is the Family Heart Database. And so it's a database of medical claims and laboratory data on over 300 million Americans. So we have procedural claims, diagnosis claims, medication claims, lab values on over 130 million. So in total, we have an incredible data set that goes from 2012 through 2021. So it's 9 years worth of data. We're just importing now the 2022 and 2023 data. And we looked in the data set to say, among high-risk individuals, how are we doing in terms of LDL control? So we pulled out the data from 38 million people who either have cardiovascular disease, or they have FH, or they're high-risk primary prevention. And it was really striking, Fred, because less than a third of those individuals are actually achieving their LDL targets according to the guidelines. And so despite all of the different therapies we have, statins and ezetimibe, and they're cheap and they're generic, we're doing a terrible job in terms of controlling LDL cholesterol. Because we have data dating back to 2012, the average follow-up in this study was 60 years. And so we were able to say, even if somebody gets to goal, how long do they stay at goal? And what was fascinating, you would think that normally if you achieved your goal, it's kind of like nirvana, you would want to stay there forever. And yet we found the average time that somebody stays at goal was less than 6 months. And people kind of cycle on and off therapy. They cycle above and below goal. And what was also interesting is that 80% of clinicians never prescribe combination therapy for people who are high risk. They tend to just stick with statin monotherapy. People get to the level they get to. And so, it's a huge issue that we have in terms of controlling LDL in this country. And so we're really trying to put a big educational initiative with all the stakeholders to try to move the needle on that.
Well, that's what I was about to say. And I think you touched on a little bit, but maybe you can go a little bit deeper. How much of that was associated with practitioner behavior and what the physicians are doing and ordering, and how much of that might be associated with adherence from the individual side?
Yeah, I think we're facing a tremendous amount of apathy in the space. So, of course, LDL cholesterol or hypercholesterolemia, like hypertension, is asymptomatic. You don't know you have it. In some ways, people draw a corollary between high blood pressure and an adverse outcome like stroke in a much more much finer way, I think, than they do in a high cholesterol. So high cholesterol is kind of, well, it can gum up your arteries and maybe you'll increase your risk of a heart attack, but people don't necessarily draw that direct link between my cholesterol is high or my LDL is high. I'm really at risk. I need to do something about it. So there's clearly some apathy. I think the biggest challenge we face, though, is that the quality measures and how we judge how payers and healthcare practitioners are doing in terms of control is not control at all. So the quality measures have changed in 2016 to right now for CMS and for NCQA. For somebody who has atherosclerotic cardiovascular disease, the quality measure is, are they prescribed a statin and are they adherent to the statin? And so it really is not LDL based. It's not, are people actually achieving a certain
It's a process
target?
measure.
It's a process measure.
Instead of an outcome measure.
Yeah, it would be like
Exactly.
for hypertension. I mean, the hypertension metric is less than 140/90 is the quality measure. If we replace that with, are they on a diuretic or not, and not whether or not is the blood pressure control, that's the same kind of
Right.
nonsense we've gotten to with LDL. And so that's one of we advocate for a lot of things. That's one of the things that we've joined a number of the professional societies to advocate with CMS and NCQA that we need to get back to where we were in the early 2000s, which was we actually had an LDL cholesterol control metric. And I think that will be a very helpful thing.
And that's something we've been pushing from the population health side for a long time. We got to get beyond measuring process, measure true outcomes. We have these indicators out there. Grab a hold of them and let's use those as the measures.
Yeah,
So
totally
fantastic.
agree. Totally agree.
Fantastic. So where's the organization going from here?
Well, as you mentioned, we're getting into increasingly to lipoprotein(a). So the population of FH people in the U.S. is 1 to 2 million. The number of people who have a high level of lipoprotein(a) is 60 million. So it's a much larger population. Our mission expanded dramatically in 2021 when we took that on. And right now, there's nothing that you can do, but there are 4 exciting therapies that are in development right now for high levels of lipoprotein(a). And so we're working to raise awareness. And I think our community in general is really appreciative of all of the investment that is going into the development of these products, because each one has to have a large cardiovascular outcome trial to test this hypothesis of, yes, high Lp(a) is a marker. If it's high, it's bad. You're at increased risk for cardiovascular disease. Does lowering it reduce your risk of events? Because we've been burned before with the whole HDL cholesterol story.
Sure.
HDL looked like it was great. It's a epidemiologically very strong predictor. But when you raise it with things like niacin and CETP inhibitors, there's no impact on events. And so all the 4 companies that have drugs in development are investing in these large 8, 10, 12, 15,000 patient outcome studies. The first we should have data sometime late next year from the lead compound, which is pelacarsen from Novartis. And so we're excited about that. And then there are a couple that are right behind that. And so we'll soon, I think by late next year, have an answer to whether or not lowering Lp(a) lowers risk.
Mm-hmm.
We certainly hope so. For our community where people have a high level of lipoprotein(a), they feel like it's a weight hanging over them, because it's not much you can do about it. You can manage the other risk factors, but it's like I feel like this sense of dread because my Lp(a) is high, and so we're excited about trying to raise awareness, encourage people to manage the other risk factors, and just continue to push forward on it.
Well, fantastic. Thanks so much for joining us, Hilly. Great discussion on this issue and glad we were able to raise it.
And maybe one other thing I'll say.
Sure, please, go right ahead.
Fred, quickly, is one other thing that we launched about 3 years ago is a care navigation center. So if there are people that are struggling either with, we know the time in primary care is precious now. Oftentimes there's not a lot of time to explain LDL, why it's bad for you, why is lipoprotein(a) bad for you. So we've launched this care navigation center. Right now, we're up to 3 care navigators. One is a genetic counselor, one's a nurse practitioner, and one's an expert in public health. And they're there to provide that education, that support. If somebody's been denied access to a therapy through prior authorization, they can help navigate that. They can do a referral to a specialist. If you're uncomfortable or unhappy with the the clinician you're currently seeing. We have a whole specialist map that they can steer you towards. And so this Care Navigation Center has been incredibly successful. And we have, as I say, 3 folks who've dedicated themselves to really engaging with the community and making sure that people's journey is just a better and more productive journey.
Well, actually, I want to thank you for bringing that up. I think care navigation is near and dear to my heart, and that the Family Heart Foundation is doing that is fantastic. That's one of the key things we could be providing to patients to help them better get through our system and work through this rather complicated healthcare system we have. So thanks again, Hilly.
Thank you, Fred. Have a great day.
And thank you for joining us today. If you like this show, you can find all our episodes at amcp.org/podcast, on our show page at healthcarenowradio.com, or on your favorite listening platform by searching Healthcare Now Radio. You can follow our show's social hashtag at AMCPListenUp, and don't forget to share, like, and follow AMCP.org on LinkedIn, Twitter, Instagram, and Facebook. I'm Fred Goldstein for AMCP. Until next time.